Good evening. My name is Kent Dix, and I'm CEO of Life 365. Welcome to our sixth in a series of webinars related to COVID-19, telehealth, and remote patient monitoring. Before I introduce our panelists for this evening, I want to take a minute and thank all the healthcare providers, first responders, family caregivers, home healthcare workers, child care providers, food and grocery delivery, transportation, healthcare manufacturers, and many others. Thank you for your service. I also want to let you know that everyone will be on mute and that we will accept questions via chat and try to entertain a few questions throughout the webinar. We have reserved some time for questions at the end. If we don't get your questions, we will answer them after the webinar and post the recorded video on the life365.health website or www.newnormal.buzz tomorrow. Now I want to take a minute and introduce you to our distinguished panelists. First, Vincent Caimano, CEO of Peer Support Solution. Vince is the co-founder and CEO of Peer Support Solutions and a seasoned executive in the areas of human performance and IT. He is a recognized expert and pioneer in the area of behavioral health technology, especially with regard to virtual peer support. Prior to his present activities, Vince has served as president of Human Performance Consultation, Inc., senior manager and human capital architect in Accenture's organization and human performance practice, and practice director in the human capital, change management, and organization diagnostic areas at Watson Wyatt Towers, Piran, and Opinion Research Corporation. Vince earned a PhD in organizational psychology from Washington University in St. Louis, and is a graduate of the Managerial Policy Institute at the University of Southern California. Vince currently serves as director of the board of the National Association of Peer Supporters. Welcome, Vince.
Good to be with you, Kent.
Thanks. Neal, Sofian. Neal is CEO of Tuzag. Neal is recognized nationally for almost 40 years of innovation in population-based and corporate and payer health management and engagement. Neal is currently the CEO of Tuzag, a conversational AI omni-channel health concierge company. Their platform delivers one-to-one ongoing computer-mediated conversations, content, and service offerings across any communication channel, driving exponentially greater consumer behavior change. Neal commercialized the first and largest telephonic smoke cessation coaching program in the United States, Free and Clear, which was an Alere company, and many of the early health-related social networking platforms, including the American Cancer Society's Cancer Survivors Network. Neal holds a master's degree in public health from the University of Missouri School of Medicine. He is also a working potter, sculptor, and has done stand-up comedy in a vaudevillian show. Welcome, Neal.
Nice to be here. And I used to shelve books at Washington U. That's as close as I got to a PhD there.
There you go. Right. And then we'll figure out more about that vaudevillian side as well in the show. Next is Jim Bowling, co-founder and COO of Premedex. Jim Bowling is a co-founder and senior executive of Premedex, an Atlanta-based healthcare software and services company that provides data-driven patient engagement solutions to over 40 hospital systems and hundreds of physician groups throughout the U.S. At Premedex, Jim heads strategy and ongoing development of an enterprise patient engagement platform and analytic tools that have supported over 3 million virtual patient engagements and thousands of successful clinical and service-related interventions. If you're interested in receiving a full list of potential remote care codes and a sample ROI and cash flow analysis, we'll give you the contact information for Jim at Premedex at the end of the show. So one of the things I normally do at this point, and I don't really want to be a downer on it, but we're talking about COVID-19, is kind of go over some statistics. So 3 weeks ago, we had about 2 million people in the world that have been diagnosed with coronavirus or COVID-19, and today we almost have 4 million. Last week, the US alone has topped over 1 million people. Actually, 2 weeks ago, they topped over 1 million people positive. And today it's 1.2 million people. So it's an increase of 20%. It's 20% in a week. We've had 20,000 deaths in the US 3 weeks ago, and today we've had 75,000, close to 75,000, so almost triple. 6 million people have been tested to date, and we have 330 million people in the US. Communities have started to open back up. Neal's already back on the beach with his Speedo, and we'll talk about. Healthcare resources have been strained to capacity. Are we starting to see the flattening of the curve? I always ask that. Did isolation help? You know, I really want to throw this out to Vince first, right, to talk to you a little bit about. With your background and what you're doing at Peer Support Solutions, how are you addressing COVID-19? How are you dealing with it today?
Well, Kent, we are throwing everything we have at it because the demand is so tremendous for our services. The number of new subscribers that we had in March were triple what they were the month before, and in April, quadruple the number that we had before. So we work with a whole variety of organizations that for a number of years have been working with people virtually using one of our platforms to help people with behavioral health, chronic illness, or rare disease challenges in their lives. And now they are increasing the number of meetings that they're hosting. And we're even looking at innovative ways just to cram more people into a meeting so that they can be with each other and they can help each other through this challenging part of their life's journey.
So why don't you explain a little bit about what you do, Vince? So when you talk about you have meetings together, how does somebody get involved from a COVID-19 perspective?
Yeah, so we currently have 2 platforms where we have services available. One is called Support Groups Central at supportgroupcentral.com. The other is called Hey Peers, like Hey Peers.com. And Hey Peers is also available as an Apple app in the store, in the Apple Store. And with both of these apps, you can find groups that are sponsored by a variety of different organizations, most of them nonprofits, that provide an hour or an hour and a half meeting for relatively small groups of people. So maybe somewhere between 8 and up to 15 people, depending on the length of the meeting. And they're facilitated by either certified peer specialists or certified recovery coaches, or someone that comes out of the organization that's sponsoring the meeting who has lived experience with the kinds of things that are troubling their participants. So most common for us is we employ a number of people for meetings that we host or that we provide staffing for. We employ certified peer specialists. This is someone who has had a behavioral health issue, has been able to learn enough about how to manage that so that they've been able to achieve their recovery and maintain it over a period of time. And then they've completed a program which is specified differently in different states, but they've completed a program that a state has put in place, and they often have to do, they have to have continuing education units. We provide, for the people that we work with, we provide clinical oversight of their work. We provide support to them because, of course, their work is very stressful, especially in these times. But even under normal times, whatever that's going to be in the future, they need support as well. So we do a lot of things to help them so they in turn can help others. And their job in our meetings is really to get the participants to help each other. That's the essence of peer support. So they may know a little bit more about some of the issues that are being dealt with, but their main job is to facilitate a really useful conversation. In some of our meetings, we also mix in evidence-based content. So we help people to remember some of the important things that they should be doing to support their wellness. So things like effective sleep habits, or how to begin and maintain a program of exercise. And then we also have more pointed tips, things about like cognitive behavioral therapy, which is a form of therapy that's really helpful for people with depression and some other issues. And we have things like material on light therapy, which is really helpful if you're suffering with depression. So we try to balance having some helpful science-based information along with the opportunity for people to come together and support each other. This is tremendously important to folks, as you might imagine, as they deal with much higher levels of anxiety, loneliness, relationship issues, which are being exasperated by the fact that they're now clumped together with people that they may have those issues with, or they may have problems in terms of being disassociated with the people that they love and that would normally support them.
Yeah. It's interesting. I'm going to stay with Vince just for a second, but are you seeing different areas that you're specializing in around COVID, healthcare workers, family support groups, right, that are out there, people that are dealing with COVID patients themselves? I mean, you're probably not just concentrating on, drug and alcohol dependencies and other dependencies that are out there right now. There's probably a lot of things that are, especially the healthcare workers, it's amazing what I saw them go through, especially in New York City over the last 3 or 4 weeks, and then also trying to prepare for what's going to go on now potentially in fall, winter, and spring. They're just going, I just went through a disaster. Now I see 9/11 coming to the nth degree. What am I going to do about it, and how am I going to take care of my family, and how am I going to take care of myself? So
it's interesting you mentioned that, and New York City in particular. We're working right now with a very large nonprofit, a $1.2 billion nonprofit, to put up a service, especially for healthcare workers. We're going to have several groups per day available for healthcare workers, and we're going to, as we roll this out, one of the geographic areas that we're going to focus these services on is New York City, where we anticipate that there's a tremendous need, and that there will be, as you're suggesting, for the foreseeable future. So this is really important. Some of those healthcare workers are coming to our existing groups, but we want to have a service that's going to especially support them. Those groups will be facilitated by healthcare workers. So again, people who are peers that understand what it's like to be in the position of someone who is dealing with the stresses and challenges that they do in the COVID crisis.
Yeah, it makes sense. Interesting enough, I'm going to go to you, Jim, here next, but I keep on hearing people go through and say, we need to bring back retired healthcare professionals, people that have come out of the industry. And I keep on thinking that telehealth is probably the perfect thing for them, because they can sit in a room like this, they can help with counseling, they can go through and help with even diagnosing or doing a telehealth call, and not put them in an ER or a hospital where they're close to a COVID patient. It's just, to me, it's just perfect. So Jim, let's talk a little bit about Premedex, and kind of give an overview of your services and transition of care, and how you can relate it back to what you're doing with COVID-19.
Sure. Thank you, Kent. Well, as you know well, our company focuses on the transitions of care. So we serve as extenders to our hospital system clients. So we have a lot of large system clients, some smaller, some local clients that are working to manage patients during that critical post-discharge period. We go in with our technology, our ability to manage multiple programs around different diagnoses, with different communication channels, whether that's live, automated, text message, various means to engage patients when they leave the hospital. So that's a really critical time, anytime during patient care. And so it's been a very critical part of readmissions programs for our clients, as well as driving HCAHPS and patient satisfaction. We look at that care transition as a critical point in the recovery of the patient, but also in managing the patient life cycle. And regarding COVID-19, it's just made it more critical than ever. Managing that patient when they're transitioning, it's very important to manage them effectively and make sure that when they get home, they have what they need, they get their medications, they can use remote monitoring equipment and quickly connect to their physician through telehealth. So a lot of patients, after they get home, they've had a traumatic experience, they don't want to go back to the physician office necessarily. They're trying to stay away. So using our automated calls, our live triage with nurses and other non-clinical staff, we can stay in touch with patients, but also monitor them through remote monitoring and engage them through telehealth. So it's really, these are some telehealth and remote monitoring in the post-acute environment has really taken off here in the last 6 to 8 weeks. It's really been because of necessity, and our protocols have been completely rewritten around engaging patients, where our prior experience was more around managing the patient experience and overall satisfaction. Now we are really engaged in managing that patient's well-being and helping them transition to keep them well and maintain contact with them throughout that critical 30-day period, but beyond. So we have programs that are extending beyond that 30-day period now through remote monitoring and telehealth to drive revenue for our clients. And that's another critical piece of this puzzle, as we've seen about a 60% drop in patient volume. Our hospital clients are suffering financially, and they're looking for other ways to drive revenue. It's very fortunate that they have opportunities through remote care management, remote monitoring, and telehealth to drive additional bill codes and take care of their patients while also driving some revenue that they've lost. So we've seen almost overnight just a dynamic shift in the way our clients are engaging patients post-discharge and the way they're asking us to engage them. But it's been very effective, and we've learned a tremendous amount in the last 6 weeks about COVID and what we can do to keep patients on a positive course after they arrive home.
Yeah, it's interesting. I think every one of you on here, when I look at you, is somebody that helps keep the pressure off the health system. They just do, right? Whether you're doing it before they get to the emergency room or whether they're post-discharge, right, to do that. And Jim, in your world, I assume you, like you said, you're shifting to where you're going upstream, right, to try to go through and try to catch patients before they even get to the hospital. And try to keep them from going into the ED or the ER. It's going to be incredibly important for us to bundle these services together as companies to be able to help provide that services then with partners like, AMR Ambulance that we work with and others they're trying to keep people out. It kind of makes it holistically kind of work from that perspective. So let me go up to one of the things I was going to mention, Jim, while I'm still with you. I always use some use cases right now, and my team kind of chuckles at me really quickly. But one of the first use cases I use that we're addressing is, I call it the Chris Cuomo. And the Chris Cuomo is, you've already been diagnosed with COVID. You are home self-quarantined. You have to, I'm all about now test, monitor, because there is no treatment for that right now. And we don't know when you test if you're going to stay negative after you go negative. You're not going to go positive again. whether you have the antibodies to go forward. We just don't know a lot of this stuff. So on the Chris Cuomo, you know, each one of you on here is somebody that can help in the Chris Cuomo, you know, circumstance, whether it's Neal, which we'll talk about, and connecting to people in a patient engagement side, while he's going through, you know, assessment up front and then 14-day quarantine, or whether it's Jim, you're working with them on a clinical basis, right, to be able to do that and try to get biometrics and behavioral and everything else, and whether it's, you know, Vince and your team that's trying to psychologically, you know, kind of support and bring Chris Cuomo's together, right, that are out there as well. Chris and he was able to get online on CNN every night and have a peer support group, a very, very large one, to share his experience. But I assume that's what other people want to do too. I guess I don't have COVID, thank God, but that's what I guess I'm doing, right, with the webinars right now as well, and bringing the peers together. And then the other one was a use case around early discharge. It's like we saw in New York City, they got to maximum capacity and hit maximum capacity, and they needed to discharge people out sooner. That's where we can reach out to our partners and go through and say, AMR, can you actually transport these people home? Can you take baselines with them? Can you actually monitor them from a distance to do that? But then the family around that patient has to be helped from a peer support area, right, from it. They have to be monitored with transitions of care. So those two alone are very critical ones that we're working on. Now there's another one we're getting ready to work on, and that's traditionally what we do is remote patient monitoring, but it's on a very, very large population to try to keep that chronic care management population off of the health system. It's preparing in a very large system to try to go through and say, can we keep the people that are congestive heart failure patients, the people that normally hit the emergency room, can we keep them out to take the load off so they can handle the COVID traffic that's coming in? By the way, the highly vulnerable population too, we don't want them in the emergency room. We don't want them around COVID patients as well with that. So anyway, I just want to kind of go through those use cases that as we talk about them. So Neal, can you hear me? Have you got audio or?
I can hear you perfectly.
Okay, because one of the Neals was saying that they didn't have audio. So anyway, on that, but I want to switch to you really quickly. Sure. And talk about Tuzag. Why don't you give me just a little bit of brief background around Tuzag and about some of the efforts you're doing with COVID-19?
So Tuzag is all about is building computer-mediated conversations. How can I, across any channel, whether it's chat, text, voice, even tailored video or print, how can I build a capability to have an ongoing, really personal relationship through essentially an AI relationship, so that I can expend my reach to millions of people if I need to, and yet make it every single conversation be unique to that one person. And that it is all about how can I do that and building it so that every conversation is contextually relevant to Vince versus Jim versus Kent versus Neal, because we're all different people. We all may have the same issue, but we don't necessarily respond the same way. We don't necessarily have the same family situations. We don't have the same circumstances. We don't necessarily respond to the same metaphors even. And so it's important that we be able to build conversations and relationships that are unique to the individual. But then the question is, how can you do that through scale so that we can reach the millions of people? To your point, how do we make sure not everyone's descending on the ER? How when somebody comes home and they're needing to get through the hospital and their family can't necessarily come and visit, how can we maintain those relationships even at a distance? So in all those cases, it's how do we build those conversations that can be done using technology, and in some cases using the technology to drive you back to services like what Vince is doing. Sometimes you can use the AI to get you back to people. Sometimes you can use people to get to the AI. And sometimes it's all about connecting it together and providing dashboards so that everyone's seeing what others are doing.
Right. So do you have some examples of how you use your conversational AI? One of the things I was going to do is make Alexa, right, as a fourth panelist on there, but you know.
Sure. Let me introduce you to Jamie. I just happened to have her with me.
Sure.
So, and we did a little thing for you, Kent. So Alexa, start Life 365 demo. I'll run you a few times.
Good evening. We're excited to share our demo for Personalize. And I see Neal as my demo buddy. checking in from Seattle. I certainly hope you've been listening to Governor Inslee and are staying inside and social distancing, even though it has been beautiful there lately. Before we get started, let's set up a couple of patient details for the demo. First, what would you like the patient's name to be?
Kent.
Kent works for me. I like him already. In this demo, Kent has a dog. What would you like the dog's name to be?
Doug.
I would play fetch with a dog named Doug. Good call. For demo purposes, did Kent take his medication?
Yes.
Got it. Kent has a dog named Doug and took his medication. Let's get ready to demo. Good evening, Kent. Thanks for checking in. Is this an emergency?
No.
That's good. You know I like to make sure you're okay whenever we chat. So, how's it going this evening?
Terrible.
Oh no. How did you sleep last night?
Really bad.
Sleep issues could be contributing significantly to your terrible day. According to your Caribou, you're taking your medications appropriately. Did you have any issues?
Yes, I did.
I see. What kind of issue?
It made me nauseous.
I'm sorry you're feeling nauseous. Avoid strong food odors and try what doctors call the brat diet: bananas, white rice, applesauce, and toast, to see if that helps. If your nausea persists, let your doctor know. Have you told Dr. Ross about your nausea?
No.
I see. Would you like me to let him know you're having issues?
Sure.
You've got it. I'll text Dr. Ross right now. And that's just a short example of what's possible. Would you like to run through the demo again?
Yes. We'll do it one more time. A happy way.
Excellent.
No, there you go.
Would you
There
like
you
to
go.
use the same sample user information?
Sure.
Right. That's great. So it texted Dr. Ross, right?
Did text Dr. Ross, yes.
Okay, good. That's great.
Is
So
this
Vince,
an emergency?
that's we'll let Alexa take care of that.
Yeah.
That's
So
good.
Vince, I
Now I'd
wanted to
like to
kind of
make sure you're
go
okay.
with you really quickly on.
Alexa,
So tell me.
pause.
There you go. I wanted to go with you really quickly on, that kind of, you've got more of the human touch that's out there. I mean, we've got Alexa. Jim, are you using any type of Alexa platform as well in Premedex, from that perspective, or how do you think this kind of tool would be useful in your populations that you're dealing with?
Well, we think there's a great feature in these types of devices. So far, we've been using, we do have decision analytics and some algorithms that run in terms of telling us what to ask patients and how to manage their protocols. But we have not deployed Alexa yet, and we think that's a great opportunity and I think a great way to engage patients in real time when they're having an issue. So, we have talked a lot about it, and I think it's kind of the next turn of the dial for us is to start implementing these types of solutions in the home. We talked about 80% of all discharged patients either through live calls, automated text messaging, and about 7 to 10% of those over a 30-day period have an escalation or an intervention need. So we love the idea of combining that with Alexa, who's always there with you and can always prompt you for a reading on your devices or just get you in touch with us as needed. So we're kind of the concierge coordinators that would interface with Alexa and then escalate that back to the appropriate folks either in the hospital or the physician practice.
And to add on to what Jim just said, one of the things you can do is there's no reason. So for example, the work Kent does, there's all sorts of devices that can be Bluetooth so that you don't even have to have, I'll say Amazon device so she doesn't ping. The Amazon device will just know things that, did you take your pills? Are you having issues around your pulse ox? What's your blood pressure? Bed sensors, have you moved? Have you gotten out of bed? Have you opened a refrigerator? All that can then be fed to her so that she can have a conversation with you and then can do two things. One is can contact a provider, could also contact a family caregiver, in essence, to say, hey, your mom needs support, you need to call her. And it can also create dashboards so that way the providers and caregivers and coaches can actually say, know all these conversations that are going on and can be even dumped into something like Epic so that it can become a note so that they know that these are what's going on and can become part of the continuum of care. And then as the provider provides that information, that becomes data that goes back into the conversations. So the Amazon device will then pick up the conversation where the live person left off. And that this can then be done not just through voice, but if you want to do this through chat, you want to do it through SMS, you want to do it through a tailored email that then sends out recommendations and support to you, all that needs to become one seamless community or an ecology of care that includes everything from all the communication technologies to the human, to the providers in one seamless integration.
So I was going to ask, that makes a lot of sense. So I was going to ask Vince, do you think we're, I already know the answer to this, but I'm going to ask the question anyway. Do you think we're at the point where, Alexa is going to be good enough to be a peer support group for somebody or a peer for somebody to have a conversation?
Well, we think that the human touch is really the most essential part of the equation. I agree with Neal that there are a lot of things that AI can do to enhance that human connection. And in our product development roadmap, in fact, we want to use AI to better match people to someone who can support them really well and to nudge them and to provide helpful tips and to encourage them to do things that will move them along on their journey. But we don't think that an artificial conversation is going to take the place of what someone might like, what someone might really need when they're struggling, especially when you think about it in a group context. If you've ever been in some kind of support or therapy group, you know how fantastic it is to be able just to sit there and listen to what other people are saying. And sometimes that's tremendously healing and uplifting in itself. We've had people that have come to one meeting and they've said, oh, you know what? My problems aren't so bad. I'm actually doing pretty well. And that's been a big lesson for them, and they've gone on and done better with just one interaction. And then for other people, they need ongoing support, and they need to be encouraged. They need to be heard. Maybe they don't have family, especially now we have so many people who are staying in, and they have very little contact with anyone. Maybe they were introverted. Maybe they were highly anxious before all of this, and now they're more anxious. So I applaud what Neal is doing. I think that AI can be helpful, and especially I think with regard to some of the more specific clinical and healthcare directives and helping to get a person through all the myriad of things that perhaps they need to do to achieve wellness. But with regard to supporting folks, I think that the human element is the most essential.
Yes, that makes a lot of sense. So, Jim, from your perspective, do you think we could start using Alexa to do some pre-screening? We have a great partner as part of our business, which is Avicina, that does a lot of assessments. They have over like 30, 35 different protocols for screening to try to help service a patient and pinpoint a patient better to the services that they need, especially going into a decision support system. But do you think that we need to have, can Alexa actually go, can I go through and say, Alexa, I don't feel good today, and start going through and saying, well, do you have a temperature? Did you lose, taste or smell? You know, do you have shortness of breath? Have you been around somebody with COVID lately? I mean, I'm not a doctor, so I'm not going to do the protocol. But do you think they could initially do some screening to help take the burden off the system? And then one follow-up to that really quickly is even those those symptoms that I just said on Alexa, we're now learning that those aren't even a good indicator for determining if somebody has COVID or not, right? I mean, so these platforms have got to be incredibly fluid, right, to be able to go through and change protocols as we learn really what we want to start screening people for on a regular basis. So sorry, the original question was, do you think it could be used to help with pre-screening on COVID?
Well, we definitely think there's a role there for initial screening, and you know, we really think that the key is to manage what the patient, the preferences of the patient, the way they want to engage. Some patients would feel perfectly fine with engaging with Alexa. Others wouldn't understand that and wouldn't probably wouldn't be the right channel for them. But you know, during a transition on the other end, we're asking a patient their preferences. How do you want to be communicated with in the future? So we're gathering those types of data points and then using that to manage patient engagements moving forward. If they say, yeah, I'd like to use Alexa or some sort of AI tool, they feel comfortable with that, then we certainly would want to provide that to them. So we think it's all about patient preferences and how they feel comfortable in engaging and providing that information. On the initial screening side, it's definitely a great way if this does really get to a point where we can't manage it with our current staff, then Alexa's a great alternative to that. And so we think it's a great tool and something that should be used in tandem with live support.
Yeah, I was going to say myself on that, if I was going to use Alexa, I wouldn't use Alexa to go through and try to diagnose me. I just wouldn't probably do that. But I would use Alexa to go through and say, Alexa, I'm not feeling well, you know, and go through maybe 2 or 3 questions to go deep, and then go through and say, would you like me to set up a telehealth, you know, call for you, right, to do that, and then route it back to my phone, right, to make it more convenient. Go ahead, Neal.
I would tell you, looking at the research that folks like Shirley Turlington have done around robotics and other things, that the ability to tailor, if you can build contextually relevant and nuanced content, that actually people will respond. Some people, and to Vince's comment, there are some people who absolutely would only do well in a support group. There are some people who actually don't want to, you know, the people who get online and are lurkers. And then there's people who simply do not want to talk to other people, that this is actually a preferred channel. And so to Jim's point, preference is everything, and that you need to cross all those channels. But I can tell you, I had a conversation with my mom near the end of her life as we were beginning to build these things. I said, could you imagine having a device that in the morning would start and say, hey, good morning, Bubbles. How you doing, sweetie? And she'd say, I feel awful. And she'd go, oh, what's up? And it would actually have that ongoing conversation. Hey, should I let your son Neal know? No. Oh, okay. What can I, you know, but what's going on? I feel nauseous. What? And then she'd have can I send you some information that might help? Yes. And then she ends up going saying, hey, don't forget Rachel Maddow's coming on in 30 minutes. You know, that it becomes, and so the issue is not the technology, it's the ability to be contextually relevant to that individual. Where the technology begins to fall away. Yeah, she learns and becomes personal. Now, I'm not saying that's what you should do instead of people. I'm just saying 2 things. 1, not everybody wants people. And 2, we just don't have enough people to do all of this stuff.
Right.
So we need to integrate it.
We'll stay with you for a minute, Neal, on this. So I always going to take this back to COVID and telehealth, because that's the series. From that perspective, if you, and you probably are already contributing from a COVID perspective, you could use your technology from the Alexa side of this to be able to go through and try to pre-screen and to assess, right, patients along the way. That's one routine you can do, right, to be able to do that, right, to try to keep the demands off of telehealth, right, as a precursor to telehealth, because I think telehealth's getting pretty busy right now.
Yep.
And then using Alexa after that, when you are in the Chris Cuomo phase, or you're in the early discharge phase of this, that you actually could be the precursor to actually interacting with a group or a person to be able to forward them on to Premedex or forward them on to Vince's group for peer support, right?
Right, absolutely. They can become she can become a great concierge. And by the way, it can be any device. It can be Google Home or whomever.
Right.
In that way, or it can be chat, or so you can do it with your thumbs, you can do it with your voice, but absolutely you can do the things you're talking about. I think that there's the critical element is integrating all the pieces together. So that it becomes a united thing. And then you can even use this. So for example, and there's a lot of ethical issues, and I think you have to think a lot about permissions and how it works. But once we have more and more tests out there and we have the data on that, then how can we use it around contact tracing to then say, hey, Kent, you came up positive. I know where you've been the last few days because you gave me permission, big word, permission, to see where you've been and track your phone. Can I ask you some questions? And then it's got to have a way to then forget you afterwards so that we can use it. So there's a lot of applications that we can use this. Think of how do you extend people through technology, but all the problems that come with doing people have to also be addressed when using technology. You don't get to skip any of the human or ethical steps just because it's technology. In fact, I would tell you it's more important to address them.
Right. So Vince, would you be concerned if you were doing some type of COVID assessment, right, on Alexa? Would you be concerned that Alexa knows that you tested positive for COVID, right, from that, or your personal HIPAA information, right, from that? Is that a concern of yours?
Yeah, I want to just emphasize that I don't think it's either or. I think it's both. I think that there's a great role that AI can play and help me to get to the proper care that I need more quickly and more efficiently. I think that's so important. So I think that working in parallel with people, I mean, and this thing about preferences is important to us too. So if you're looking for peer support, well, there are many different flavors of peer support. That's why we developed our new platform, Hey Peers, which it includes not just scheduled meetings, but one-on-one video support, as well as text options and text groups that you can get involved in. So we're giving people more of a range of ways to connect with other people. And again, that's for someone who's already decided that they're looking for peer support. It's not the end all or be all, but it's certainly something that can assist someone when they're in challenging times.
Do you have a specific group of individuals that engage and more likely to engage in your services? And Neal and Jim will go out the same way too. Are you seeing? I used to probably be stereotypical on this, that seniors are less engaging, since I'm getting closer to that group. Seniors are less engaging. I guess you're a senior now if you're over 50. Because that's what COVID says, is that you're a senior over 50, right?
I have a Medicare card, so
there you go.
I am a senior.
So that's what Cuomo was saying this morning, because if you're a senior, you're over 50. So because of COVID. So are you seeing certain groups that actually would go through and engage more in your services on peer support? Are millennials part of this? Are seniors part of it? Is it middle of the road? Who engages in your services?
Yeah, it starts really with millennials and goes up to maybe 60 or 65 years old. We often think that older people have fewer technical skills, but that's less and less true.
Right.
Older people have smartphones. If you look at different socioeconomic levels, there are smartphones at every level. And so we're engaging people on our platforms pretty easily in almost every demographic. It's the very young folks who seem to be very text oriented that are a little bit less, have been less of the market that we serve. But that's starting to shift as we're going to Hey Peers, where there's that texting opportunity.
So millennials, do they want to use less video and want to do more texting? So are they more inclined to talk to an Alexa, or are they more inclined just to do texting from that? Jim, what's your experience with this with Premedex at all from your engagement with your group?
We definitely see a skew towards texting among the younger population, and that is, but as mentioned, that is changing, and more people, just depending on your preference, some people don't want to engage with someone on the phone. We do find that most people do appreciate a live interaction with a human being, but a lot of times health systems can't afford that. It's just not practical. So that's where automation comes into play. Even though you might want a live, warm interaction with every patient, it's just not practical. So that does dictate the types of solutions that we use. For example, high volume or emergency department engagement post discharge from the ED. We're using a lot of text messaging and IVR there. And we do see a better response rate among younger demographics for sure. And, I think it's to be seen. We don't have any data yet on Alexa, but I think that it could be a great tool for any demographic after they are used to it and have a certain comfort level that there's going to be a human being response after they have an escalation or intervention need. So
it's interesting, really quickly, and I'll go to you, Neal, next, but just a really short, little story. But my mom, her son invented this, wireless, cellular IoT device that connected to the back of INR devices for a Lear, would automatically send her readings to the cloud. And so she didn't have to talk to a nurse. That was more cost effective to do that way. They learned that it was cheaper to go through and put an IVR system in place. And what she did, instead of putting a INR value in of 1.5, she would put it in as 5.5, or just the opposite. It was just the opposite. And it would invoke an alert to be able to call a nurse, because she wanted to talk to a nurse. She wanted to talk to a human, right, from that. So she learned how to game the system, right, from that perspective, which was beautiful, right, to do. And to me, that's just part of patient engagement, right, from that. It may cost a little bit more, but if you're going into a swerve, turn into the swerve, right, or into the curve from that, if she's going to engage that way, then engage her that way, right, correct, from it. Right?
And I would tell you, it's not just a matter of, is it millennial versus Gen X or versus us boomers. I think it really is a matter of circumstance. There's times where, particularly with more transactional things, you tend to want something that's fast, simple, and easy. As you move into more support mechanisms, it changes. You're probably going to want more in the way of people, certainly in the way of voice, but it may be support amongst some of the Generation Z are going to still want it to be text. So the conversation technologically still needs to be just as personal. But personal is not dictated by the endpoint. You can have a personal chat, you can have a personal voice, you can have a personal person. All of those can be personal, and depending on your circumstances, people are going to migrate through all of those systems. Some people will strictly be people. And you know what? For your mom, that's exactly what we should provide her. For people who want to really only use their thumbs, God bless them, let them use their thumbs. For people, and for people who are somewhere in between and moving back and forth, that's what we have to do. Of course, that predicates that the knowledge base and the conversation base is crossing all those channels, so that every channel is learning from the other channel, so that it's integrated in how you structure the ongoing support. And then the endpoints of how it manifests itself, that depends on the need of the person.
Yep, makes sense. So Jim, really quickly, we're starting to run down on time like we always do. These things go really, really fast. Sorry, Vince, from that. I'll go with Vince first. And I always take this back to COVID. So from a COVID perspective, and what you just heard from, Alexa solution to a little bit more hands-on solution. It's not hands-on, but a little bit more interactive solution with Premedex that's out there. How would you see being able to benefit using this with COVID, with peer support groups and bundling it together potentially with these other services?
Yeah, I think that one of the great things that we could do is provide the human touch, but leverage that time, that labor expense across a number of people. And that's where we get some scaling potential, even when we try to keep human beings at the core. So, for example, you could have, as we do on our platform, you could have a group of women who have had a cardiac experience come together with one person that's answering all of their questions. They're learning from each other. They have some educational material in there so that maybe they're at the same stage in their recovery, and they're all, you know, there are some key things that are being emphasized across the board that they all need to be reminded of and be doing. So I think that there's this chance to leverage the human touch in that way.
So what's your thinking? I just kind of came to mind on this, but what's your thinking around of gamification, right? And using gamification in peer solutions. Does it have to be video? Does it have to be texting? Can they be in a game itself from that standpoint, even maybe with different personas, right, to be able to interact with each other? Because a lot of seniors, I'm going to stereotype again, like to sit there and play with their tablets and be engaged some way. I know my mom does, right? From that, is that a way to get her engaged into her care?
Yeah, I got to tell you, we've had some discussion about that, but that's not in our business model right now. So I'm probably the wrong person to ask. I'd be curious about what Neal and Jim think about that.
Neal, your thoughts?
To me, I think the notion of game mechanics, I'd rather think about, because I hate the word gamification personally.
Okay.
Game mechanics, but I think you're really talking about behavioral economics. How can I nudge people to do things? And I would suggest in the long run, if you're using extrinsic motivation, it's short term and it has to escalate to maintain. I'd say it's way more important that I understand, what does Kent Dix care about? What's meaningful to him? What are his values? What's going on? Is he a Phoenix Coyotes fan, or does he like to go hiking? So that I can build metaphors. So that way I build the intrinsic capability to have a conversation with you that you lean into because it's meaningful to you. I think we've spent too much time on, and don't get me wrong, I think there is room for games. I play games. I like those things. But I think too much in healthcare, we've looked at using incentives and extrinsic motivations to get people to do stuff, and then we're disappointed when they quit doing it the minute we turn off the reward. You know, if it's all you're doing is responding to the M&Ms, you don't get there. So I'm much more wanting to say whether it's peer support, because that creates that contextually relevant conversation. That's what's so powerful about peer support. Or through the technologies I'm talking about, it's making it so that I go, yeah, that's right. That's meaningful to me. And it's almost going back to the work Viktor Frankl was doing in terms of meaning out of why did people who survived well out of concentration camps, who did and who didn't, or POWs. And it was the ability to find meaning to create the context for the conversation. And I'd say, I wish we'd spend more time on that than the other.
Okay. Makes sense. So Jim, from your perspective, I was going to ask you about gamification, but the people that come to you typically, let's just take a payer, so let's take a provider that has a 30-day readmit issue or readmission issue on this. How do you keep people engaged in your solution, engaged in the transition of care home, right, from that?
Well, it's a critical time in their life when they're very vulnerable, especially now with COVID-19. So most patients that we deal with stay engaged with our programs because they know they're fragile, they need help, and they are motivated to take the advice that we have and the healthcare organization has for them. So we have pretty good response and participation during that 30-day period. I think when you go beyond that, that's when gamification does have some benefits, and we like to think of it as more challenges around how do you achieve your optimal health. and how can you measure that? Just like an Apple Watch and closing your rings. It is kind of a fun game, but you also get some health benefits from it, and you can actually see that over time. So we like the idea of tying the game or the challenge to their overall health care. We also have used gamification in rewarding and for staff recognition within the hospital. That's been one of the kind of unexpectedly one of the greatest drivers in our business is recognizing healthcare workers for the jobs they're doing and getting direct patient feedback from patients who are just in the hospital, who are recognizing people. And we use gamification in a sense to reward staff, and it has been huge during COVID-19. And really one of the drivers in our business unexpectedly is rewarding staff with great comments from patients and personal feedback. So we're working around gamification in that way to see, have a friendly competition among healthcare workers, and they're all anxious to see what patients are saying and the great job they're doing and what that does for their overall patient satisfaction and quality of care.
Right, makes sense. So we're going to wrap up here in just a few minutes, but I want to go around to each one of you and just kind of ask really quickly. First of all, Jim, where do you see COVID-19? What do you think fall looks like, winter looks like, and spring looks like? I'd like kind of your thinking from that, and how are you going to prepare your business to address either an increase or a decrease in COVID-19? Your thoughts?
Well, it's hard to say. I mean, you look at the news, you read one thing, you look at different websites, and they're different measurement techniques, so it's hard to really know exactly what's going on. We do see a decrease in the cases within our clients, so that's very positive. We expect, unless there's a vaccine of some sort, that we're going to see a reemergence of this in the fall, and so we're preparing now for that, whether it happens or not, and hopefully we get a vaccine or something in place. But it's probably, unfortunately, going to be some time before that's made readily available. So we're preparing, our clients are preparing, and we've got to also help their other patients feel comfortable with getting back into their care setting in the inpatient and outpatient settings, where we're seeing a lot of patients are still very tentative to go back in to receive health care that they need. So we're working hard with them to strategize and build those programs with the anticipation that unfortunately it's probably going to be back, and we'll see another emergence of this. We have to prepare that way, and hopefully we'll be pleasantly surprised.
Do you think we'll have rolling quarantines between now and next year?
Well, I would think that we would have to, if we see the same sort of trends that we saw early on. There obviously we have to keep the economy going. It's a trade-off, and it's a very delicate balance. But so we think there's going to be a very aggressive new protocols around keeping the economy going and strong while we manage patients and hopefully reduce and minimize the effects of this virus. But we have to prepare for the worst.
Agreed. So Neal, really quickly, do you think that if we did go to rolling quarantines, and I want to ask you about your forecast, as well, and where you're going to position your business, do you think that we selectively quarantine, that people that are over 65, retired already, maybe retired, maybe not retired, that they're more isolated, and the younger population potentially is not as quarantined or partially quarantined? So first of all, what do you think, where we're going in fall, winter, and spring, and how you're going to position your business, right, as well?
So being an old public health guy, this is kind of like what I went to graduate school for 45 years ago, was to talk about exactly these things that, everyone says, hey, how could we have ever predicted this? And they go, we have a science, we call it epidemiology, and it's been around for a while. So I think all the epidemiological science says this is not done, that we are going to deal with this for some time, and until there's a vaccine, and that's going to take some time. There's going to be reoccurrence. It's going to come in pockets and waves. I think we're going to watch waves of it happening based on how people migrate right now. And that's why rural states are beginning to see spikes now. How that's going to affect what we do, quite honestly, I think is not really about COVID itself. I think the toothpaste is out of the tube. I don't think we're ever going back to doing healthcare the exact same way. The notion of, where people would go into an office for a visit to find out they were getting their blood pressure checked and they were going to talk to a nurse for 5 minutes, they're going like, that ate 3 hours up of my time. Why the hell did I do that? Why can't I do that using technology? Why can't I use that using telehealth? Why can't I have a virtual diabetes visit with a group of other people who are going through the same things as me? So I think the real issue is going to be reconceptualizing the very nature of how we do healthcare. And the focus I have is how can I become part of the glue that puts all that together through technology, and the grease that then facilitates the engagement. And then on top of that, we're going to have to figure out, how do we rethink about paying for the outcomes rather than the procedures? And then how do we keep the healthcare system from not collapsing because of the mountain of debt they live on from all the buildings they're sitting in?
Yes. So do you think we're doing selective quarantine going forward, or it's going to be a variety?
I think so, and I think sadly it will be a lot of politics as opposed to just being tied to the science.
Right.
And that's going to be unfortunate, because politics, I won't even go into which politics, but politics will only slow down things. They will not. Politics do not help. The virus doesn't really care about blue and red.
Yeah, I get it. So Vince, from your perspective, where do you see this going over the next year or so, and how are you adjusting your business to accommodate for it?
So I think that COVID has set some very big forces in motion that are going to be with us for a long time. I think this is going to be a little bit like people who lived through the Great Depression. That people are going to be more cautious and more anxious in general in their lives forever. The people who have gone through this, because they'll always be worried about, even after we have a vaccine, they're going to be worried about the next pandemic and how is that going to happen, and can it happen again, and so forth. The other things that have occurred as a result of this is a lot more people are more comfortable now in getting virtual support, and a lot of organizations that are coming to us now are saying, we've been thinking about this for a while, so maybe now we have to do it. And so I think life is going to change in the aftermath of all of this, and we're going to be doing things differently, and we will adapt, but we will live our lives very differently than we have before COVID.
I hear you. So I need to wrap up because we're over our time, but I want to thank everyone for attending this evening. I want to take a minute to thank our distinguished panelists, Vince Caimano, Neal, Sofian, and Jim Bulling, for your participation and great insights as we implement telehealth and remote patient monitoring and start defining the new normal in healthcare. I'm sorry that we weren't able to get to all the questions tonight, but we will post the answers on the Life 365 Health website and www.newnormal.buzz, as well as the recording of tonight's webinar. Please be safe and healthy, and we look forward to having you join us for the next webinar next Wednesday, May 13th at 7 p.m. We're calling it Testing, Testing, Testing. Is this working for COVID-19? With Christina Noble, Chief Growth Officer from Snorg Quest Diagnostics, Dr. Kathy Petty, CEO of MoDX AI, and then we'll have a special panelist on as well. So everyone have a safe and a great evening. Thank you very much for attending.